Bueno, tengo que usar la mascarilla porque es el protocolo del auditorio. Buenos días a todos, bienvenidos a esta plática de la doctora Elizabeth Weinberg. Voy a hacer una breve introducción de su trayectoria. La doctora Elizabeth Weinberg es profesora titular en el Departamento de Ciencias del Cuidado de la Salud en el Colegio Universitario Merit Cederschiöld en Estocolmo, Suecia. Su principal área de investigación es la enfermedad de Huntington, pero además también trabaja en la clínica de la enfermedad de Huntington en el Departamento de Neurología del Hospital Universitario de Karolinska, igual en Estocolmo. Es autora de más de 50 publicaciones y le damos una cordial bienvenida a la doctora para hablarnos de este tema tan fascinante que es la enfermedad de Huntington. Welcome to Mexico and our School of Medicine.
Gracias. Buenos días. Gracias por estar aquí. No más habla español, perdón. So now I will move over to English. Okay. This talk will be in two parts. First, I will give a review, an overview over what Huntington's disease is. And the next part will be results from a research study on predictive testing and the long-term psychosocial impact of predictive testing. And I realized that there are different knowledge about Huntington's disease in the audience. So I have prepared a basic presentation about Huntington's disease so everyone can follow. So I'm working in two different places in Stockholm. I'm working in Marie Cederschiöld University College, and that is 80% of my time. And I'm a senior lecturer at the nursing program at University College. And then I'm also working at 1 day a week at the Karolinska University Hospital. Maybe you have heard about the Karolinska Institute with a Nobel Prize, and it's the connecting hospital. And there I work at the neurology department with Huntington's disease patients. As a specialist nurse. Okay, so I give you an overview of what Huntington's disease is. And the clinical features is that we have a triad of symptoms. We have neurological symptoms, we have psychiatric symptoms, and we have a cognitive decline. And the neurological symptoms are involuntary movements, including chorea mainly, but sometimes it's more dystonia and or Parkinsonism. And the cognitive decline or dementia is severe, but it looks a little bit different, it appears a little bit different than, for example, Alzheimer's disease. The psychiatric symptoms, usually it starts with depression, anxiety is very common, poor impulse control, irritability, and in a few cases also psychosis. Also apathy is quite common, and a personality change, a change in personality. The age of onset, usually the disease occurs in the mid ages, like 30, 40, 50 years of age. But there are children who get Huntington's disease, and that's the juvenile part who gets it before 18 years of age. There are about 10% of them. And we have a wide range of age of onset, so even up to 80 years of age, we have seen that. But usually in midlife. And before onset, you have no clue, or you don't have any symptoms that can be related to the disease that comes later. It is, as you maybe have heard of, it's a genetic disease, and it has an autosomal dominant inheritance. That means that if you have a mother or father with the disease, you have 50% chance of getting it yourself. And if it affects both female and male equally. And unfortunately, there is no treatment, no cure for the disease today, and it's a fatal condition, and death occurs usually 15 to 20 years after symptom onset. But that can be a wide range too. The main areas of caring is actually not the neurological part, which is can be very devastating as well. It looks you can really see it, but the main areas of caring is the nutrition part, because these patients, they lose weight easily. They have a higher what do you call it? When metabolism, a higher metabolism, and also the movements creates more energy, or it takes more energy. So they must be on a special diet with extra calories. And they also have swallowing difficulties. That comes more and more during the disease. And sometimes in the end of the disease, in late stage, they must have a feeding tube, PEG, the percutaneous endoscopic gastronomy, so they can't swallow at all. Another area of caring is their mental health. So they usually have depression, anxiety at least, and irritability, and they need medication for that, as well as nursing as well. Another area of caring is the dysarthria, that they have slurred speech will develop. So they have difficulty to express themselves, and it's hard to hear what they are saying. So it's important to early on start to get tools for communication. Many patients also have sleeping difficulties that needs to be addressed, either with self-care or with medication. And also I added the dental and mouth care, because many of them are using these antidepressants, and they get a dry mouth, and that affects, of course, the mouth care. That they need to go to the dentist a couple of times a year. And that's why it's recommended to have a multidisciplinary team for these patients, and that is what we have at the Karolinska University Hospital. And there is a long list of professions that are involved, and we have meetings every other week to talk about patients, because we need every perspective from all of these. The neurologist, of course, the psychiatrist, the specialist nurse, speech pathologist, occupational therapist. We do a lot of home visits to see how things are working at home. Physiotherapists and psychologists, and in particular a neuropsychologist, social worker, dietitian. That is part of our team. And then we have a collaboration with another department, with the geneticist and the genetic counselor, who are doing the diagnostic test and the predictive testing for Huntington's disease. Okay, so now I want to show you a patient. Let's see if I can make this work. It did work before. All these technicalities. Keep our fingers crossed.
Saladet a 9.50 y aguacatejas en Maya.
We did it before. We tried it, but okay. Now, oh, gracias.
So Anne-Marie, how's your chair for you?
Lovely.
Lovely. What was your other chair like before?
Comes from uncle.
And you found that you would slide down the chair and fall? Yeah?
Well, I think you got an idea how this disease can look like. We're back? Yeah? Okay, so what is this? Why is this happening? The etiology of the disease. Do I need to? Okay. No. It's this one. Okay, gracias. Okay, so why is this happening with the body? Well, the disease is due to a CAG expansion in the Huntington gene on chromosome 4. The CAG, it's the DNA sequence of repetitions of the CAG repeat in this protein called Huntington. And we all have the Huntington, and we all have the CAG repeats, but for that causes the disease is that you have a big part of it. You have more than 36 CAG repeats. That causes the disease. And the number of the CAG repeats is important, because the more CAG repeats you have, the earlier you get the disease. So it has an inverse correlation to age of onset. But as you can see on this slide, there is a wide range. So there's a lot of people who have it between 40 and 50, and it's hard to tell exactly when they are going to get the disease. But as the even more repeats you have, the lower. Then you have the juvenile, the children who gets that. They have a lot of repeats. So what does Huntington, this protein? Well, we don't know a lot of it, but some of it. What we know, it's important for brain development, and by studies when they had reducing the normal expression of the Huntington gene leads to abnormal brain development in mice. So in particularly brain development before you are born is very important for the Huntington. And we know also that the Huntington is causing protein aggregation that leads to neuronal death. So that's the overall, and then the cellular functions of Huntington protein is still not completely understood, but these are some of them that I'm not into at all, so I can't really answer questions about those, but some of you might know about these, the chemical signaling, transporting materials, regulate gene transcription, and protect the cell from self-destruction and apoptosis. And that is here the neuronal death. And this is how it looks with the one wild type brain, the neuropathology. This is a normal brain, and this is a brain with Huntington's disease in the late stages. And as you can see here, atrophy of the striatum is the most prominent part. You see much bigger holes here, and it's seen in 95% of the HD brains. And also an atrophy, it's in particular the basal ganglia that is affected. Also atrophy of the frontal lobes. 80% of the HD brains show atrophy of the frontal lobes, as we can see here. But however, 20% are apparently normal. And the epidemiology is interesting. The prevalence is about 10 persons per 100,000 people in the North America, Europe and Australia, or I would say Western Europe and Australia. However, it's probably underestimated, but it's a low prevalence in Finland, Africa and Asia. And here you can see the red countries are those with the highest prevalence. Here's North America, here's Sweden, here's the rest of Europe and Australia. Mexico is here between 1 to 5 persons per 100,000, so a little bit less than the rest of North America. But then we have this in Venezuela. We have a very high prevalence in Venezuela. That is much more than 10 per 100,000. And that's actually where they found the mutation, studying families in the Lake Maracaibo in Venezuela. And as you can see, there are white countries and there are no, it's unknown. So I would think it's the rest of South America, it's present as well, but we don't have any prevalence studies. And the genetics of Huntington's disease is that it actually, we can see anticipation. And anticipation is a process that means that you get a lower, or the age of onset is decreasing per each generation. And we can see that in some families. And it's particular if it occurs when the mutation is inherited from the father. And that is what we think is due to the meiotic instability in sperm cells. The sperm cells are dividing every hour compared to the eggs, who we all have a set part of eggs and they don't divide and make new eggs. But the sperm cells are constantly getting new cells, and we have done studies on sperm cells, and we can see that they vary. The CG repeat number is varying a lot in the different sperm cells. And then there are, in some families, there are actually 2 patients with Huntington's disease who get an offspring, and in particular in Venezuela, where we have these large families with Huntington's disease. And so they can actually have a homozygosity, that they have one gene from Huntington's disease from the mother and one from the father. But it doesn't mean that they will get a more severe phenotype. And up to 10% of all cases are spontaneous mutations. And that is what we think happens when the CAG repeat. Maybe they are like 30, and then it gets generation by generation, it adds up. Maybe next generation have 31 or 32, and later on in generations it will reach the number of CAG repeats that causes the disease. Treatment. Well, I said that there is no treatment, there is no cure. There is treatment, but there is no cure, but only symptomatic treatment. And basically it's the neuroleptics, the first and second generation of the neuroleptics that we're still using, and antidepressants. That are the main symptomatic treatments that we can give these patients. I don't know if you have heard about tetrabenazine, but there is some benefit. Some patients are using these, and it has some effects on the movements, but not for the dementia and the psychiatric treatment. But it also has multiple side effects, so we have to be very careful with this medicine. Okay. Well, what can we look forward to? Well, we have been hoping. It was actually in 1993 that the mutation was found, and at that time, the research groups thought that within 10-15 years we will have a treatment or a curable. We will know much more, so we will have a very good treatment, and still, unfortunately, we don't have that. We have had a lot of different research trials, clinical trials, and but it has not been successful. It has not been successful. But now, in 2020, this year, there is a new American study called Proof HD, where they will try to use predopidine. I am not sure how you pronounce it, but that hopefully will boost production of the brain-derived neurotrophic factor. It's a protein with neuroprotective properties, and that will start now. It's a multi-center study that will start this year. There has been a big clinical trial about antisense nucleotide therapy that unfortunately had to be stopped after one and a half year. It was La Roche, Roche pharmaceutical company who stopped it, and it was because they couldn't see. Probably it was not because they couldn't see any benefits. So then it was not ethical to keep on with this 3-year trial, I think it was, and that was a big. Well, the whole HD community was very sad about that. Okay, and I also wrote down here the restorative neurosurgery that actually was in Mexico. I think it was the first one in Mexico, and I'm not sure if you are still doing it here. It's the same kind of restorative neurosurgery that you do for Parkinson's disease. That is also on it's only in research, it's not a clinical treatment. But what you do is that you transplant human fetal striatal cells into the brain. And we have seen some benefits. The grafts that you put in the brain are accepted, but they don't last so long. So probably it has to be done several times. But there were some benefits, absolutely. And then I read about another study with deep brain stimulation, DBS, which is actually a clinical treatment for Parkinson's disease. And they have done studies on that, but I'm not sure how. They saw some benefits, but that's mainly on the movements. And as you have seen, it's not only the movements that we want to cure. It's the psychiatric, it's the dementia. So it's complicated. Okay. Now I think we are going to move over to the next part. And before I do that, I just want to introduce the predictive testing for Huntington's disease. We can do predictive testing. We can do diagnostic testing. It's a blood test that you investigate the CAG repeats in a blood test. So it's pretty straightforward to do the test. But the predictive testing is special because you do it when you don't have any symptoms. You do it to get to know, do I carry the Huntington's disease gene? Will I get the disease or not? So that's looking into the future. So to know that or not to know it, that is actually the question, and it's a difficult question. And because what will you do? What to do with the knowledge? Because there is no treatment today. We can't do anything exactly to prevent the disease. It's just to know. So what do you know with the knowledge? And onset, do I want to know when I get? We can actually look into how many CAG repeats you have, the number of them, and relate that to, it will be probably that you will get the disease before 50 years of age, or before 40 years of age, or before 60 years of age. We can't pinpoint exactly when, but we can give some directions if they want to know. And the last question, will I cope with the knowledge? So persons who have a 50% chance or risk, I would say, risk of having inherited the disease, they are asking these questions, of course, because there is knowledge, there is technology to look into the future. And about 20% are actually going forward to do this predictive testing. So most persons don't. But those who want to go, who want to know, they really, really want to know. And before they actually, it's not that easy to just take a blood sample and send it in and get the results on a letter, on a phone call. You need to be part of a program. It will take some time, even though the blood sample is quick. It takes a week to analyze this, but we want them to take some time to really think it through, so they don't jump into something that is, well, we can't turn time back. So it is a tricky question, and I think right now we should have a little 3 minutes break, just to stand up and give some new blood to our brains before I go over to the next part. But during that time, stay here, we will just move a little bit around and think about this. Think about, what would you do? Now you have seen the disease, you know what it is about. Would you actually would like to know that you are going to get this disease or not? It's a hard question. And then I will tell you about people who have done it and what they have, their experience with knowing, both having that I will have the disease and not having the disease. So let's just have a couple of minutes of break, and it's important that we all stand up and then you think about this. So 3 minutes. I can have some. That's right, and we will, yeah, that's right. Yeah. Oh yes, it's a lot of it. It increases the cost, the living cost, very much, and also with the aggression that they are throwing things and things breaks, and yeah, it's a higher. Yeah, it is. It is. Yeah. Okay, are we ready? Everybody has been using their legs a little bit. It's actually very important. Okay, so maybe we should start off with any questions on this first part with on Huntington's disease. Yeah? Is it okay? Do you hear me through the face mask? Yeah. Yeah, that's right. Yeah, so bear in mind now what you would think. Now I will present some research results. And this is the aim of the study was to explore the long term, and the long term means over 5 years since they did the predictive testing, and the psychosocial impact. So what are the consequences on life with knowing that they either will have the disease or will not have the disease? So study 1 included, and this is a qualitative research, so we don't have any statistics, but you will hear a lot of voices. I have a lot of citations, so we get closer to the persons here. We move on from the statistics. So in study 1, we interviewed 10 mutation carriers. There were 6 women and 4 men, and they were between 34 and 62 years of age. In the next study, we had 21 non-carriers, 12 women and 9 men, and they were between 25 and 69 years at the time of when we interviewed them. But it had to, for everybody, it had gone at least 5 years since they had done the testing. The methods for both studies was we did semi-structured interviews. We tape recorded them, and later on we transcribed them word by word, verbatim. So we had a lot of papers actually with exactly what they said during the interview. And then we did qualitative content analysis, where you look for common themes that everybody is actually talking about. So we don't hear, the themes are not only from one person, it at least 2, 3, or maybe 10 or 21, that all of them. So to make a theme, it has to be several persons who experience this. And the topics during the interviews was, first of all, practical issues about their career. Had they done anything about their career? Education and family planning after the predictive test results. And then we talked about emotional reactions. We had an interview guide that we had these questions about. And first of all, we talked about how they could accept the test results. And for those who were gene carriers, we talked about how they were thinking about getting the disease, and feelings of guilt, which I will talk about later on. That is for both groups, actually. And the last topic was social implications, how this have affected your family, friends, and fellow co-workers. And here are the themes. The first theme was changes in practical life. And some of them did actually found out that, and now we are talking about the mutation carriers only. So I'll do it in 2 groups different. So it could be that the knowing that you are going to get the disease was either a motivator or a hindrance in their life. So there's one citation here, and that is an example of a motivator saying, when I got the test results, it was like push to make the best of my life. So they really want to get on with their life and do the best of it. Another one thought it was a hindrance, and this is a citation. It is a really long educational training, and there is no point of starting it. And today I'm very skeptical toward what I will remember. So this person was quite young and didn't want to pursue a training that she actually wanted to do, but she felt that no, there's no point of starting it. In terms of family planning, so before persons who are at risk for having the Huntington's disease There are different perspectives, I would say. Some people, they really don't want to have children at all, just because of the risk of keep on the disease to next generation. But many persons actually want to have children, and they think that, oh, when in 30, 40 years of time, then there will be a cure, and that will be fine. But this one, now we have the mutation carriers. Some of them had already had children, but those who didn't have children and was a mutation carrier. And there is a citation here about family planning. I think I would do it if the situation arose. This one was a single person. They could be healthy too. And it doesn't really matter if they are gene carriers. They might have come up with something by then. So they had the experience themselves being a gene carrier, and it was maybe not too bad. You can cope with that. And again, they might have come up with something new by then. So that person would like to have children. Another theme was different emotional responses, and there is sub-themes. And the first one is relief from uncertainty. And actually everybody in this study, both mutation carriers and the non-carriers, felt a big relief with just knowing. And even if it was a bad knowing, this person said there is a security in knowing what the deal is. So it's very stressful not knowing for some people, and they want to know how to plan ahead and know what the deal is. Adapting to the test results were another sub-theme. Some of them adapted very quickly, and some did not at all, I would say. And here is one who says, now I'm starting to feel that I have learned how to live with a gene. Now I have to start learning how to live with becoming sick. So there is a process first just to accept the test results, and later on, when the disease started. None of the persons at the interview had symptoms, so they were all healthy persons. But this could be like 5, 6, 7, or even longer time after the test results. Something that most of them, the gene carriers, said that they felt a more appreciation of life. And that is actually something that other diseases has shown. If you get cancer, for example, and you know that you are going to die, then you feel more, life is more precious, the time you have. And this is what they expressed as well. So here is a citation. It is best to take the time to do fun things. I'm going to have as much fun as I can for as long as I can. I have become happier, or one appreciates life more. But there were also some of them, out of those 10 mutation carriers, we had those who actually regretted taking the test. So there were 3 of them who regretted the test. It was harder than they thought it would be. And this is a citation. I never imagined that thought. I was so sure of not having the inherited disease. It is tough that I have done it. Hope has disappeared. And this is one major thing with hope. If you don't know, you can still hope that, I mean, you still have 50%, and you can hope for that you don't have it. But hope is gone when you know. And what do that do to yourself? Hope is actually a very important notion for your health, that you hope for something. But they can also hope for having a good treatment, hope for that children doesn't have it, and so on. So hope is very important. But for this person, she or he felt, no, it has disappeared. Another theme was about the social relations, how it affected their families, friends, and fellow co-workers. And one sub-theme was that they felt it brought the family closer. And this person says, it has gotten better, closer, better, nobody not knowing. Everyone knows what they have to adjust to, so it feels calmer. So there is a common theme that it feels more secure to know, and it's calmer, that everybody in the family knows there's, and they can, they are into this together, because this is also, it doesn't affect only the person who gets the disease, it's a matter of a family disease. And then there was we had questions about how they actually, had they started planning for onset, planning for having the disease, had they made any adjustments at home to take care of the involuntary movements and so on. And they were actually, that was a topic that was really hard to talk about. They didn't want to talk about it. So we were very careful about this topic, and no one really talked a lot about it at all. So one person said, that was the whole idea behind the test to do. They thought that I'm going to plan for the disease, for onset. That was the whole idea behind the test, that one could do that. But it goes down the drain, I can tell you that much. It doesn't work at all. No, not at all. So it was very hard to get into that planning mood. It was probably too sensitive topic, I would say. And this would be very interesting to actually do another study on, to really get into more details about this particular topic, and how can we help them? How can we help them with this? Or do they just want to, no, I don't want to talk about it. And another theme was feelings of guilt among the mutation carriers, that they felt sad about having will have the disease, and to put on the same risk to their children. And there is one citation here, I think my son also has it. That is even worse than knowing for herself. It is horrible. So this is it's tough. And maybe if you have children yourself, you might know that actually it's much worse when you see your children are sick for some reason than dealing with your own symptoms and diseases. So it's the same for them. Another issue that was hard for the mutation carriers was informing the children how and when, and how do I do that? because you put on a big risk for them to have the disease. And one person said, it's hard, it's so hard. I'm thinking that I want to tell, I'm thinking that I don't want to tell. How should I say? What should I say? When should I? I know that I was so angry at my mother because she concealed it. She hid it, and it was hushed up. I hated it, and now I guess it is not as hushed up towards him as my mother was towards me. But I feel that it is something that has to do with him, but it is so hard. How should one say something like that? So this informing the children is actually a very sensitive topic in the HD community. The families, some families, they don't want to talk about it at all. They are neglecting it completely, I would say. And that is not, our experience is that it's not good to do that, because when it comes to, it makes clear that it is in the, you have the disease, it will be a lot of anger towards the parents who didn't inform them. But it's a very tough issue. Okay, so that was the mutation carriers. And now we move on to the results of the non-carriers. And one could think that the non-carriers, well, they are just happy to, well, I don't have the disease. Wow, now I can just go on with my life. And but it's not that simple, I would say. And we'll show you about that. First of all, there was a wonderful, great relief for the non-carriers to get rid of that risk, of course. And there are some citations that are really happy here. It is definitely the happiest day of my life, happier than when the kids were born, to be honest. This relief, it was so extreme. So that's the major benefit with having getting the disease, getting the test. Sorry. Another person said, I really felt like I had gone 11 years imagining symptoms, and it's amazing how strong symptoms one can imagine. This person had been worried every day, looking for symptoms. Every time she was tripping over something, doing a little bit stupid things, or you drop things like we all do, she thought immediately, wow, I have it. Now it's the onset. So to get rid of that feeling was wonderful for her. And then we had, as well as for the gene carriers, we had a motivator for life. And for some of them, they did really actually prominent lifestyle changes. And this person, he was a young, don't read the, yet I just give you the story about him because this is kind of exceptional. He was 18 years of age, the age where you can go for testing. And he had been waiting for that. He really wanted to do this testing. His father, his uncle, his uncles, his cousins, his grandfather, there were many in his family who had the disease, and he was so sure that he had inherited as well. So he was in his youth, in his teenagers, he was really doing a lot of stupid things and being with criminals, and he had a very not good behavior, I would say. So this is what he said. He tested at 18 years of age, and we met him like he was 23 years of age. So this is a citation. I imagine that the disease was extra strong. I'm going to get it, guaranteed. I'm going to die young. I only live now, not later, and that had the effect that I was not scared of dying, and I did not care about the future. I did not have any thoughts at all, no plans what I wanted to be when I grew up. Old, that's something that I will never be. So I took quite a lot of unnecessary risks in my youth, jumped between rooftops and things like that, with the attitude, if I fall down, I die, it doesn't matter, now or in a few years, what difference does it make? So, and he was with a gang who actually had a lot of criminal behavior as well. And when he got the results that he was not carrying the gene, he completely changed. He said bye-bye to the gang, and he went into university to study, and he had a girlfriend, and he got a family when we met him like 5 years after the testing. So that was a wonderful, wonderful story of what life brought him with the test results. Okay, so now we are coming to those who actually had some problems with the test results. So we could see a theme that we call need of reorientation, that they actually thought, were thinking, who am I now? They had lived with this risk of knowing that they will have the disease, or they thought that they will have disease, and now it's no longer an issue. They had not had any plans for future, and how do I do that now? Who am I now? So in need of reorientation, and here is an example, a citation for that. You build a wall, brick by brick. It took a couple of years, and then it appears the wall is not needed. Let's tear it down, but you can't do that in one move. You have to tear it down slowly, brick by brick. It takes time to process. And I think that is quite a nice metaphor with how long it takes to actually to put down your guards, so to speak. She had been prepared for the disease all her life, and now she had to adjust that, no, I can have a future as everyone else. And she needed some psychological support. Another sub-theme that or actually quite a few of those who got the good results, was what to do with this second chance in life. They had to do something very extraordinary because they had won the biggest prize in the world. So this person, this is a citation, I felt that now I have received a second chance, in some way, a second life, a new life. And then I don't really know what to do. All of a sudden, you are supposed to be happy, right? And really blessed and think that everything is a walk in the park. And it wasn't. It was tough. So there were some difficult years. So some of these persons who got a good results actually had problems that actually they had a clinical depression because they didn't know how to handle the new situation. the need of a new identity was strong, and the pressure of doing something extraordinary was overwhelming. And some of the persons who were non-carriers felt also an emptiness. And here is, that could be an emptiness that lasted just after receiving the test results, or it lasted actually quite a few years. So this is citation. It is very difficult to explain what it actually was that caused the situation to not only be wonderful. Instead, there was this state of vacuum. Yes, to find yourself in the middle of all of this that became so changed. And this is interesting with the feelings of emptiness that you really have to talk about with some psychological support, actually. Okay, and then we had another theme, and it's called strong impact on family relations. And some of them were really having better family relations. They felt that they became closer to their family, to their mother, father, or sibling, or maybe not siblings, but partner. And one expressed that she felt less dependent to her husband because she, as she said, my whole life was tied to him. She felt so dependent to have a partner who was going to take care of her when she became sick with the disease. And now she was much more freer, and they were more equal, and that makes them feel much closer to each other. So that was good. And now we come to these feelings of guilt. And there were persons who expressed these feelings of guilt, what we call survivor guilt. When you don't get the disease, when you survive a big catastrophe or whatever, it's called survivor guilt. That you are feeling, why do I live? Why didn't get it? And feel guilt towards the one who didn't make it, so to speak. So this is a citation on survivor guilt. Now I had started to wonder, why should I have been the one to have made it? It was a really big deal, so why me? Why, I was not any more deserving to, so to say, make it. And my siblings, and XX is a person who was the world's nicest, had like always helped everyone, and had always reached out a helping hand, and to be affected with something like this. And then I'm the only one who doesn't get it. Yes, that was very difficult, and that was difficult for several years. She was one of 5 siblings who didn't get it. All of the others were getting the disease, and she went into a clinical depression for some years, actually, for these guilt feelings. And then we have the dynamics of the relationships between the siblings, because there are siblings who decide not to test, and some are tested. So these are the feelings towards the untested sibling who doesn't want to get the test. And this is a citation of a person who said she expressed it herself as well. So now we are not in the both of us anymore. So the untested sibling felt left outside. We are not together any longer, because they had the same risk before the test, and now one knows that she will not get the disease and one doesn't know at all. And that made the dynamics between the siblings, the sisters or brothers, hard. They didn't want to talk about it. It was hard feelings that they were not in the same boat as any longer. So that was hard. And some of them actually expressed that they had, it was hard to inform the untested sibling, because they thought that will affect them. And they proved right, I would say. So the conclusion is of these both studies that it's very important to offer all persons, regardless the test results, psychological support after predictive testing. So some of them don't need it, but you should always offer the psychological support even for non-carriers, because they have a lot of psychological issues to handle. Okay, and the final little thing is that I want to show you is that we made a study. This was in the 1990s actually, but we did a big study on so-called catastrophic events after predictive testing. I mean, how often does it happen that they actually are doing something really bad to themselves because of the testing? Because there was a lot at that time in the 90s, there was a lot of criticism of this predictive testing. And so we did, I was living in Canada at that time, and we did a big survey with, as you can see here, a study on 4,527 persons in 21 countries. And we were asking the centers to report on how many actually had committed suicide, how many had attempted suicide, or how many was hospitalized in a psychiatric hospital after predictive testing. And it was actually only, I would say only, because we had expected more, 0.97%, so about 1% had actually experienced a catastrophic event. There were 5 suicides, 21 suicide attempts, and 18 psychiatric hospitalizations. And what we saw also, that risk factors were having a previous psychiatric history and unemployment. So it's important to really be careful with those who actually have a psychiatric problematic history. But it was not only the gene carriers that was part of this, it was actually both gene carriers and the non-carriers. So, gracias por su atención. And this is just the Colmo. Thank you for your attention. Any questions? Okay, wonderful. Yes. Yes, right. Yes. Sí. Okay, yeah, you will translate. Yeah. Mm. 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 Yeah. Yeah. Well, if I understand, can you do something to prevent the disease? And well, no, not really, but we know very little about it. But what we know is it's good. What we say to our patients who are mutation carriers, we say to them that it's very good that you are in good shape physically, that you do your training, the balance because of the balancing problems later on, that if you are keeping in good shape and with the training physically, that's good. And there's no food or what we know of that actually click. No, it's not. No, unfortunately. No, no, no. But we hope for finding something that can maybe not cure it, but to slow down the progression. And it's sad. Yeah. Mm. Yeah.
Probably just trying to delay the year of onset. That will be the only thing, no? Because changing the to healthy lifestyle maybe will just delay a little bit the progression of the disease, but not avoiding.
Yeah, it's a good question. We haven't seen, it actually has been a few studies of that. Can you uh, push away the onset? We don't know exactly why it starts at a certain age. The only thing that we know is it depends on the CAG repeat number. If you have many of them, it starts earlier. Even though you have the best, healthiest lifestyle, it will start early. But there is probably, I would think there are factors that could slow down the onset, but we don't know of that yet. So just to have a good, healthy lifestyle, you make the best out of your life as long as possible is what we advise these persons to.
What somebody in the Facebook is asking, what is the expectancy of life with this disease after the onset?
The onset. So it's usually they live 15 to 20 years, but I have seen patients who have been living for longer than that, up to 30 years. So it can be a more aggressive one, and it can be a more milder. And it's usually the milder, the later on, if you are over 60 years of age, you can get a very mild version of Huntington's disease. We have a patient who is 92 years old. He actually has the disease, and he's still driving, and he is very little affected. He has it, it's for sure. So you can live a long life as well, but that is unusual, I would say.
Yeah. The same person, Lydia Susana Laino Azarini, is asking if it is possible to diagnose in the fetal stage, like prenatal
Yeah.
diagnosis.
Absolutely, you can do that. And there are persons who do that, and then they can abort if you're already pregnant, and then you test the child or the fetus, and then you do abortion, or you can do pre-implantatory diagnosis, that you take out the egg and yes, you do that outside the body and pick those eggs that are healthy, that you know for sure doesn't have the CAG expansion. So yes, you can do that.
Thank you. And Adriana Ochoa is asking, what is your experience with this disease in your country?
The experience of,
I think it's like an open question, maybe about the incidence or how to treat the patients in your country, or what your country is doing.
Okay. Let's see if I understand the question. I think it has been a disease that you are feel ashamed of. You feel ashamed of that you don't show it because it's something, and that goes for all kind of psychiatric diseases, that you don't want to talk about that. You feel ashamed that this is in your family, and then you feel not treated well because of the psychiatric part, as well as so it comes from the family that they feel ashamed of it, and it comes from the society that those with psychiatric symptoms actually are, they are not treated as well as other people with the physical diseases. But I would say I've been working with this since 1980s, and it's much more open now. I've seen a big change actually in the society. The society is opening towards all these psychiatric unhealth, the mental unhealth. So it's much better treatment from the society, and as well from the families, that they don't feel so much ashamed any longer. But there are still there is a lot of feeling ashamed, and that you shouldn't talk about it and things like that. But we are getting better.
I think that the situation is not only in your country, probably it's like a wide feeling on these psychiatric conditions. People try to hide it, but that's not correct, because if they hide it, they will not receive the medical attention earlier, and it will get only complicated.
Absolutely.
Right. Dr. Juan Fernandez Ruiz is asking, how do you compare the catastrophic events that you mentioned in Huntington's disease versus other neurodegenerative diseases, like with the family, involving the family response?
Okay.
So we're talking about the catastrophic events, comparing with Huntington disease against other neurodegenerative diseases.
That's right. Oh, that's a hard question that I don't have a true answer to, but I can just make some thoughts about it. First of all, I can say that the catastrophic events was higher in the HD families, even though you don't go testing. So there is a higher risk of committing suicide if you are part of a Huntington's disease family. Studies have shown that. And then when you go testing, we could see what happened there. For example, there is testing in other families, like Alzheimer's disease. They can also, some of them, it's an autosomal dominant inheritance as well, and they can test. And I would say, I don't know of any studies about that, but I would think that it would be the same thing, that some of them are actually having problems with suicide thoughts. Do I get the disease? Because it's a horrible disease, Alzheimer's disease as well. So it's a very interesting question, and I would like to make a study on that, actually. But
the comparison. I think that the main difference is Alzheimer's most of the Alzheimer's disease, like 99%, is sporadic.
Yeah.
So people doesn't know if they are
That's
going to
right.
develop or not.
Yeah.
And as the question of the person present
Yeah.
here in the audience,
Yeah.
I think in the case of the sporadic disease, you have a lot of things to do to try to prevent or delay the starting of the disease.
Yeah.
But once you have a genetic disease like familiar Alzheimer's disease or Huntington disease, it's impossible to avoid developing the disease.
Yeah,
It's
yeah.
just going to happen. You don't
Yeah.
know exactly when, but it's going to happen.
That's
unfortunately.
right.
Yeah.
Yes. Yes.
That's very tough.
Yeah.
And
You
people,
can't blame yourself.
exactly.
You can't blame on yourself on how you are living now.
Yeah. Adriana Ochoa is also asking similar question like before. She's asking the experience in Suecia, in Sweden,
Yeah.
about this diagnostic, the test of the diagnostic, the pre-symptomatic. I think you already talked a little bit about, a lot about what is the response of these people, no?
Yeah.
When they know the result of the test. But the Adriana wants to know a little bit more of your experience in that country.
Well, what I can add to this is that some of them who actually they want to know, they get into this kind of a program for predictive testing, and then they are in it for a couple of months, and then they actually says, maybe they have already taken the blood tests, and then they stop it, and they don't come for the results. And that is why we want to, it should take a couple of months, maybe 6 months, before you really feel like, yes, I want to go forward. Most of the persons who come for predictive testing wants to know right away. I have decided I want to do it, but just make it quick. But and they are kind of sometimes upset that it has to take some time. But afterwards, they understand that, well, it was good. It was good for me. It was good that we had this time.
Right.
And what is the time they
Yeah.
need to wait
Yeah.
for the result?
For
For the genetic result,
Yes.
how long do you need to wait?
Well, I would say 3 to 6 months. But it depends also on the person. If you see that the person actually is unstable and needs more support, and then it could wait a little bit, but at least 3 months because they have to see different professions. They have to see the psychologist and the psychiatrist and do some testing, to think about what to do with the test results. So it's not only to take the blood sample. You have to fill out forms and to think about it, and well, we think it's good.
Dr. Juan Fernandez Ruiz is asking if there is an effect in educational and socioeconomical background of the person in relation to the response of the test.
No, we haven't seen that. Not for the research I have done.
What I think is in the way that people respond to the results.
Yeah.
If they have different educational levels.
No, we haven't seen any of that actually. Okay. It is more. So one would think that if you have more education, then you could handle it better. No, or is that what?
Right.
Yeah. Because knowledge and experience give you more security, and you can handle things better, maybe. That's an interesting question as well. So I would say spontaneously, no, it doesn't matter, but we have to look into it. Actually, you could come up with good ideas here now too.
But at the end, I think that it could be indistinct of having higher education or lower education, the feeling of what is going to happen with your life. I
Yeah.
think that will be common if you have higher or lower education, because at the end it's something that is like very personal. No, what I will do if I know
Yeah.
or not,
Yes,
if I have or
yeah,
not
yeah.
the possibility to develop this disease.
Yeah.
So probably that's a common factor of human beings,
Yeah.
the way they will react.
Yeah.
Yes,
Interesting. Yes.
and yes, in my opinion, it's very tough, this decision of blood testing of
Yeah.
genetic diseases, because you don't want the patient to get into catastrophic
No.
response. So you
Yeah.
don't want them to finish their lives.
Yeah,
No?
that's
So
right.
really, I think it's important to talk to them before the testing, all the
Yeah.
possibilities. They have to know what you will do if it is positive or negative. So discuss a lot
Yeah.
before having these results, because you are talking about human lives.
Yeah.
So it's really something very delicate ethically.
Yeah. It is.
But at that respect, you show that only 1%, no, will have
Yeah.
that
Yes.
negative
Yes.
attitude, no?
That's right.
So it's not too bad.
No, it's not too bad.
I-
and
Uh-huh.
and comparing to, you have to relate it to those who doesn't. I mean, what is the I mean, to the general population, and we haven't done that at all. We know that in Sweden it's quite. We have a high rate of suicide, and we don't know why exactly. But one thing is that it's probably we register. We have a very good registration compared to other countries. So, but I'm not exactly. I don't know the numbers of the, but I think it's much more than 1%. It is. So, but here it was related. We wanted to know related to doing this test, and we didn't know that for sure, even though it was related or not, because other things in life can make you commit suicide, even though you are not dealing with or you are dealing with the predictive test results, and something else is happening that you have problems. So it's a tricky, but it was some kind of comforting to know that it was not a huge number of people who actually had a catastrophic event.
Yes,
Yeah.
That's very interesting, because if you just select randomly a cohort of population of 5,000 people and you follow them,
Yeah.
maybe some of them will commit catastrophic
Oh, yes,
events.
absolutely.
And not matter if they have some relation
No.
to that disease. So they have a proportion, as you say, maybe
Yeah.
not so different. Or
No, that's
even
right.
less, even less, as you say.
Absolutely.
So the people in the Facebook is asking for your email address, because
Oh, yes.
somebody already wrote your email. Is okay?
Oh, yes, wonderful.
Because they
I'd
want more information to read about this interesting
Yes.
topic.
love to. Yes, wonderful. Thank you. Say yes, please.
Thank you.
That's great.
Thank you. Yes, Dr. Laura Escobar put the
Yeah.
Okay. Do you have more questions? Someone in the audience want to ask something? We can help with the translation. Okay.
Wow.
So we want
Thank
to
you
thank
so
you
much for
very
wonderful
much.
questions and interesting, and for being here and listening. Thank you.
Thank you, Dr. Elizabeth.
Yeah.
You're welcome to come back again soon.
Yeah. Oh, thank you.
Thank you so much.